بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. First, I'd like to apologize for all the attendants for keeping them at this time. It's Friday late afternoon, and I expect myself and you to do something more pleasurable and more enjoyable. But that's life. You have to sometimes go through hardships, like listening to Talal Almalki late afternoon on Friday. I was assigned to speak about 3 topics in one topic, about esophageal atresia and esophageal replacement, esophageal perforation, and corrosive injury. And this is 3 different difficult topics to talk about in an hour and a half plus minus. So what I chose to do is to pick the things related to skills, related to experience, and not much of theory, knowing that all of you will be able to go through the theoretical part on your own in the textbooks and journals and so on. The objectives has been decided by the committee are the following: touch on the embryology and anatomy, classification of esophageal atresia and tracheoesophageal fistula, perinatal management, clinical findings, preoperative management, operative repair, long gap management, postoperative management, complications management, and esophageal replacement. A touch of embryology and anatomy. Before that, a little bit of history. Esophageal atresia has been mentioned in literature in the mid-16th century. There were trials of repairing the atresia since then, but the most successful, or the first successful repair of a primary of esophageal atresia primarily was done in 1941 by a person called Cameron Hyde. And since then, things started to advance very fast in the last 60 to 80, 70, 80 years in the face of classifications, operative techniques, handling difficult situations, and so on, which we'll try in the next hour and a half to go through some of them. Embryologically, things start usually around the 4th week of pregnancy, where a tracheoesophageal septum gradually separates ventrally, and the respiratory diverticulum from the dorsal part of the foregut. Around the 7th week, the esophageal diverticulum reaches its final position, and by that time, around the 8th week, the lumen is completely or partially obliterated due to proliferation of epithelial lining. And as you can see here, it starts like a small bud, then the separation of the 2 parts, the ventral and posterior, and the completion of the separation. This is a cross section that shows you that it was one thing. There's a cleavage line between them. That cleavage line started to progress more, and the complete separation, as you can notice. Esophageal atresia and tracheoesophageal fistula believed to develop from an improper separation of the respiratory and digestive divisions, and starts between the 3rd and 6th weeks and continues to be pathological or a defect, a congenital defect afterward. Esophageal atresia is around present in around 3,000 to 4,400 births all over. The commonest is a little bit in the side of females, and the highest incidence noticed statistically in Finland, where it is 1 case in every 2,500 births. What's the etiology? At least what are the theories of the etiology? As I said, esophageal atresia and tracheoesophageal fistula results either from spontaneous posterior deviation of the tracheoesophageal septum or from some mechanical factor pushing the dorsal wall of the foregut anteriorly. And it happens in all forms of what to be then type A, B, C, D, and E. So it happens everywhere. It will be noticed early on by a mother, if she, at least if she is a multigravida, that in this baby specifically, her baby is showing a bigger tummy. She's pregnant, a bigger tummy, and she mentioned that to the obstetrician. And that's a sign of polyhydramnios because the fluid is not passing through the esophagus, distal to the stomach, to the rest of the GI tract. More of the theories. Currently, most authorities believe that the development of esophageal atresia has a non-genetic basis. In 1987, Kluth has the concept that there are 2 events may happen, either separate or together. The first event is a vascular event, and the second one is ischemic event, either together or separate that may cause esophageal atresia. And this is a common theory in almost all GI atresias. If you remember, it happens, or almost the same theory happens in the small bowel, in the large bowel, and so on. 2003, a connection to adriamycin that induce tetragenesis with the formation of atresia and tracheoesophageal fistula. Okay, how do we classify them? Before we go into classification, this is atresia. Wherever you find a blind pouch, it's atresia. Wherever you find a communication between the GI system and the trachea, there's a fistula. And it could happen anywhere, in any shape, in any form. This is here, atresia with a fistula, proximal atresia, the distal fistula. In this case here, there's atresia in one piece, and then a little bit of a fistula and the distal fistula. This is the opposite of what we know. The fistula is in the proximal pouch and the atresia in the distal pouch. And this is the other form you know of, which is difficult to repair sometimes and has no fistula. This is pure esophageal atresia, and this is the H type. We call it H type. Okay, we'll come to the percentage. The first known classification, it's a gross classification with a little bit of modification by Fogg. We rely and depend on the classification of gross. As we know, you can see, the commonest is type C, which is called 3B by Fogg. You can read this later, but we depend on and rely on our classification on the blue gross classification. So if there is a pure or atresia on the proximal pouch and there's a fistula in the distal esophagus, that's type C, and that's the commonest. It goes up to 85%. Type A, which is pure atresia up and down, and there's no fistula. The proximal pouch is atretic, and the same thing here. I mean blind, and this is also blind. In type B, there is a fistula proximal pouch, and the distal esophagus is blind. And this is type E with H type fistula. It's almost close to type D here also, although there is a blind proximal pouch with it. Almost always we see this, we treat this, and our successes and failures happens here. Successes, I mean, but failures happen sometimes, or most of the times here, and here if we miss this type sometimes missed, especially if the fistula is small. Here it looks big, but usually the H-type fistula is not that big. Sometimes it is forgotten, and the patient will present with persistent cough, not like my cough, but with persistent cough. And I've seen patients who are treated for H-type fistula when they are in the late 20s, like 20 years old plus, because it was small and it closes or gets blocked and then reopens again, and problems happen. But this is very common. This is the commonest here. Okay. How do we classify them clinically in relation to the birth weight and to the congenital anomalies and to the pneumonia? The commonest are two types of classifications: Waterstone classification and Spitz classification. People, for practical purposes, they use Spitz, but both are acceptable, and you can base your clinical practice according to one of them. I'll go first to the Spitz classification, and it's three groups: more than 1,500 and less than 1,500 and less than 1,500. The first one, type 1 or group 1, more than 1,500 grams, and they have no major cardiac anomalies. Group 2, less than 1,500 grams or major cardiac anomalies. So it's either or. In comparison to group 3, both have to be there. They have to be less than 1,500 grams and they have major congenital or cardiac anomalies. Well, for Waterstone, weight differs. Type A, it's 2,500 grams or more. Type B, less than that, so 1,800 grams to 2,500 grams with mild pneumonia or congenital anomalies. And type C, all the same, less than 1,800 grams with severe pneumonia and or congenital anomalies. And we will further our discussion based on those classifications. This is just to show you, this is the same slide as before. This shows you the survival rate according to the classification. Let's go to the Spitz first. Type 1, which is more than 1,500 grams and no cardiac anomalies, they are about 97%. the survival. In comparison to group 3, in spits, it goes down to 27%. The same thing almost applies to waterstone. If the baby is 2,500 grams or more, his survival rate is 100%. If he is from group C, it goes down to 48%. And these numbers was a little bit difficult, especially for the spits. A little bit difficult to replicate or duplicate in real life in general hospitals around the world. You will see that in the slides to come. Okay, now we have a baby who's born with a differential diagnosis of esophageal atresia plus minus tracheoesophageal fistula. How to handle it? Prenatal ultrasound, which is routinely done, it picks up to 40%. It's sensitive only for 40%. In that 40%, 66% will show polyhydramnios. And this is because of not all of them with a blind, with the type 1, which is blind proximal esophagus and distal esophagus. Some of them, they have fistulas upper and lower. So polyhydramnios is a common finding. It depends if there's a fistula distally between the distal esophagus and the trachea, that there's a lymphatic fluid goes down. The stomach will not be as small as if it is type A with esophageal atresia pure. Also in ultrasound and MRI, those two findings, an echoic area in the neck and a pouch sign for the ones who are more than 26 weeks. I'm sorry, but I have to answer. Okay, as I said, this is the prenatal findings of ultrasound. This is one study on 2014, and that is not 40%, it's 90%. And postnatally, it's only 34%, small pouch, 71%. So it shows that ultrasound is much higher in sensitivity. Well, postnatally, baby is born and he is with the Prof. So there's excessive secretions, there's drooling, and as I said, multiparous mother, multiparous mother will say that this is not the same as other babies of mine. He is having more saliva. Some of the saliva will fill the proximal esophageal pouch and spill over to the trachea, and baby will be choking. If excessive saliva goes in the trachea, he may have respiratory distress. In the past, babies born at home, so they'll be fed at home, and obviously the milk will not progress down through a esophagus to the stomach, and they have a feeding intolerance. With that, they may have pneumonia also. The baby then, with this early findings, the attending physician in the delivery room or delivery suite will try to pass in his gastric tube, and he says, I couldn't. Immediately, chest X-ray will be done, and things will start to show what's happening. And this is how they push the tube. They pass it through the mouth, and this is the proximal esophageal pouch, blind. There's a trachea beside it, but it is deceiving. Sometimes, if the tube size 5, soft, and not much of experience of the attending physician, he'd shuffle it through, he'd pass it through, and it will coil inside here. And almost all the tube will be inside, and you say it's successful. So it's a must to do a chest X-ray to see where's the tip of the feeding tube or reblogo, and this is diagnostic. In the past, 20 years ago, or before, when the baby goes up to the nursery and they call the pediatric surgeon, some of the pediatric surgeons, and I've seen that 30 years ago, they will have a drop or two of gastrografin or barium, confirm the presence of a blind pouch. This is not needed, and sometimes it's hazardous. So we don't do it, because if there is a spillover, especially of gastrografin, which is water soluble, it is very much irritant to the lungs, and they may have a chemical pneumonia. So we advise totally against passing some contrast in the reblogo, and we just confirm it by this X-ray. Okay, the X-ray is helpful on so many things. It shows you a distended pouch, and usually the proximal pouch is distended, is bigger, because it's blind, and there's a lot of amniotic fluid trying to pass through, and it distends more and more and more. The X-ray is good in showing you the heart size. We'll come now to the other congenital anomalies, and we check the heart. This is, by the way, is a global. It shows us the ribs, how they look. There's any abnormalities, and abnormalities in the vertebral column, and it shows us aspiration pneumonia. As I said, it's either saliva, the excessive saliva, especially if he comes from other side, other hospital, or if he comes from home as he's fed. So it's saliva excessive for more than 6 hours, and or milk. It is also of note to look for diaphragmatic hernia. We know that if there's one congenital anomaly, we look for a second congenital anomaly somewhere. It's about 10%. So we check the diaphragm, both sides, and we check in the middle. We are not looking only for what we call bacterial hernia, but we look for orgasmic hernia. And orgasmic could be one side, could be two sides, and usually you can see it, not sometimes you miss it. I put two pictures here. This picture shows the logo and shows a tube here also, but this is an abdomen full of gas, and this is a silent abdomen, gasless abdomen. There's nothing here. And it gives you an early differential diagnosis of esophageal atresia with tracheoesophageal fistula and esophageal atresia with no tracheoesophageal fistula. So reading the X-ray immediately can give you a clue of what about your journey. What are you going to face in the next few weeks and days, you as a surgeon and the baby as your patient. Okay, rest of the workup, after we now establish sort of a working diagnosis of esophageal atresia with tracheoesophageal fistula plus minus, we have to do further work. As I said, we have to check for other anomalies. We do ultrasound for the kidneys. We do echocardiogram. We look for vascular rings if we do angiogram, and we check for a left or right aortic arch. There's a certain percentage of babies who have the arch on the right side. And it's been a tradition of some of the surgeons, when they see right aortic arch, they don't do a right thoracotomy, they do a left thoracotomy. I've seen, and I've done myself, right thoracotomies for in the presence of a right aortic arch. A gabogram, something to remember always, and this is not something to happen in the first day or the first week, but it happens later on. And this is a picture of, one of the pictures of gabograms. This is a bougie coming from a gastrostomy, from the start going up in the tip of a blind distal pouch, and this is another bougie coming from the mouth, going down in the distal, in the proximal esophageal pouch, and here he's trying to measure the distance between the two bougies and see if it is possible to take him to OR and through a thoracotomy, do a primary anastomosis. And I leave you to think about this. Is this enough, or still there's a big distance? Some of us will say, no, I think this is enough because it was far away here, now it is here, and I do primary anastomosis. And some of you, they say, no, I want to wait for another centimeter. We don't go by centimeters, we go by the vertebral bodies. We have 1 or 2 or 3. Now, as I can see, there are 2.5 maybe vertebral bodies that maybe I'll take the risk and do my primary anastomosis of the baby. I'll come to the third point or fourth point, doing bronchoscopy and esophageoscopy. And this is usually done on the table just before doing the primary anastomosis, just before doing the thoracotomy. Why we do it? We look for a fistula. This is right main bronchus, this is left main bronchus, and this is a fistula. Well, so what? Well, sometimes you may see a second fistula from the proximal pouch. This one is from distal pouch, but it could be another one coming from proximal pouch. Management differs, and you will be looking for a second fistula when you do your thoracotomy. And you check your lungs very well and take it from there and do your thoracotomy afterwards. I left it to the end, so not to deviate you from the main thinking of esophageal atresia, but this is essential. Looking for associated anomalies according to Spitz classification and Waterstone classification may alter your management. Back throw is about 25%, trisomies in 10%, cardiac in 35%, gastrointestinal in the form of atresia, Hirschsprung, perforate anus, and so on, genitourinary in the form of kidney problems and ureteric problems. All in all, anomalies are seen in a form or another in almost about 50% of the babies with esophageal atresia. Charge here, this is charge, this is coloboma, heart defects, atresia coini, coinal atresia, developmental retardation, genital hyperplasia, ear deformities. So you have to look for so many things before you look at the esophageal atresia. But your main goal, your main worry and interest is esophageal atresia. But other anomalies may deviate you from your enthusiasm to do a primary anastomosis because you have a major cardiac anomaly, because you have kidneys not functioning very well, and so on and so forth. How do you manage them? As we receive them from the delivery suite, we have to do the following steps. It's a must. Oral pharyngeal spaces should be clear, suctioned very well, and keep suctioning that mouth so no saliva will go down distal pouch to trachea. And the baby should be elevated because if he goes down, he may aspirate. Fluids start immediately, intubate if needed, and I don't intubate all of the babies. Some of the babies, the ones who are below 1500 and they have chest problems, they may aspirate it, they are not breathing very well, especially if they are premature. And we've seen just last week, the baby was 1,500 or 1,200 grams, and he's 32, 34 weaker. He has to be intubated, ventilated, and to the point he has to be given help from the NICU. I prefer to start antibiotics immediately. So this is the preoperative management, more or less, but this is sort of standard. Okay, the baby now is stable, intubated or not, breathing spontaneously maybe, here's an antibiotics, given fluids, and all the screening is done, meaning that he had his cardiac work, he has his kidneys, no anomalies in the ribs or in the forearm, and so on and so forth, and he looks that he is ready for surgery. Now comes the real work discussion. What's next? Just this is to imagine if you are putting your baby on his left side and his right side showing up to you, and you are taking his right arm up. Just imagine where's your pathology. This pathology. This is esophageal atresia. This is a common type, by the way, type C. So this is the proximal esophagus. This is the tracheoesophageal fistula, and this is the distal esophagus. This pathology here, which is the field of your surgery, is just under the armpit of the right arm, and you have to raise that and put the hand near the ear here with a sponge and everything. And you are going to operate here. This is the normal, by the way. We are looking in the pathology here. So this is where you're going to have your surgery if you are traditional, if you are classic, if you're going to do a thoracotomy, if you're going to do laparoscopic or arthroscopic, thoracoscopic surgery, well, we don't care. It will be here because you have 3 openings and you'll do your surgery. But this is the field of your work. Okay, the question comes, shall we do it now, within 24, 48 hours, maybe 72 hours? That's now, or later. And later, why and when? And if we do it later, what kind of surgery we are going to do? And this is, from now on, we'll have this dilemma. This is the question always asked just before deciding the surgery. Primary anastomosis is immediate. Late, you have 2 options, either delayed or stage primary anastomosis or esophageal replacement. And each one of those has its own indications and its own merits. Let's go. The indications for immediate surgery are the following. No pulmonary complications, so the lungs are clear. The baby is about 2 kilos or 2.5 kilograms. He has no major associated congenital anomalies. In general, he's a healthy baby. And this is important. The gap between the distal and proximal esophagus is less than 2 centimeters, actually less than 2 vertebral bodies. This is a general criteria here. In comparison to delayed surgical intervention, we say, no, we'll wait because the baby situation does not allow us to go for immediate surgery, pneumonia, especially if it's severe pneumonia, or if he has general sepsis, if there's congenital malformations, mainly if he has a major cardiac problem, if there's a severe prematurity, if he's a 600 grammer, although I've done 600 grammars, but with a controlled situation with an excellent intensive care unit. And the other problem, this is the real concern. Those are problems to worry about. You expect yourself to face them, but this is, you have no solution for it. It's the gap is more than 2.5 centimeters. It's more than 2 vertebral bodies. If it's 3 or 4, you have to think of what are my options. Also, last week, we did a baby with about 3 or 3 plus vertebral bodies, and we had to stretch it. It went well, and let's hope that our anastomosis will hold and there'll be no leak and no stricture mainly. Okay, I said early that this is the option of delayed surgical intervention. Let's talk about it a little bit. It's a continuous suction by the logo in the proximal pouch. The baby kept continuously in a sitting position. He is in antibiotics, prophylactically, and those are the options. You may give him a gastrostomy and ligation of the fistula. You may give him a cervical esophageostomy, a spit fistula. You may just do gastrostomy. I have seen it also, and not touch the cervical esophagus. This spit fistula, it's messy, and you lose some of your proximal esophageal length, but they will do it, and I've done it in situations. One of them, which I'll mention to you later on with pictures, and under difficult situations, you have to open and just ligate the fistula because there is a big air leak between the trachea and the distal esophagus. So you have to do something for it. You go inside and you just ligate the fistula and close. Maybe you do also a gastrostomy. And with the gastrostomy, you have to put him on G-tube feeds. And if you don't do a cervical esophageostomy, you have to do sham oral feeding to prevent the baby forgets sucking. Because babies, if you don't keep them sucking with the sham feeding, they forget. And you do bouginage if your blind distal or proximal esophagus is there and you want to push it further down, and you keep pushing. Same as picture I've shown you for the bouginage. But there are drawbacks. It's a long time until teeth, and it's something nursing don't like, doctors don't like, and babies don't like because there's aspiration, the tube comes out, and you have to insert the tube, and so on and so forth. And there's no guarantee for primary repair. The gap may be so long, you waited for long for nothing. You kept bouginaging him, and then at the end, it is not coming close, the two ends of the esophagus. And as I said, there's an increased risk of aspiration, and the baby forgets sucking and drinking very much. But it is an option, and it helps in some special situations, and I'll come to that also. Okay, now I come to the primary repair. You remember, we talked about spits and waterstone, and now we'll try to apply those classifications to the surgical indications, when to operate and what happened. Okay, let's go to waterstone. Let's go to spits first. I like spits. Do it, my boss, one day. If the baby is more than 1.5 kilograms and he has no cardiac problems, you have to go immediately, and this is type 1. And this is with an excellent prognosis. The mortality is less than 2-3%. And the baby is 97%. If the baby is less than 1.5 kilograms with a cardiac problem, or more than 1.5, much less than 1.5 kilograms, but no anomalies, he believes in delayed. Delayed means in his hand, a reblogal, continuous suction, and so on and so forth. Staged is there for the ones who are much less than 1.5 kilograms, the babies with cardiac anomalies. And the stage means that you will just ligate the fistula and gastrostomy and hope for the best. The baby lives. If his cardiac surgery is successful, you have a gastrostomy to feed him, and you have a fistula ligated, and you can take it from there. Waterstone, on the other hand, if the baby more than 2.5 kilograms, go for surgery immediately because he has no pneumonia and no anomalies at the same time. His lungs can take it, and he can stand the surgery, and it is successful. Waterstone classification says that success rate here is 100%. If he's between 1.8 kilograms to 2.5 kilograms plus pneumonia plus anomalies, he has to have a delayed kind of repair. If he's less than plus anomalies plus pneumonia, he goes just for ligation of the fistula plus gastrostomy. So life is not rosy always. This is the primary anastomosis. Look here in this drawing here. There are a few things to mention. This is a dilated proximal pouch. This is a distal esophagus. This is the fistula about to be cut. Notice that there is discrepancy in the size and diameter between the distal esophagus and the proximal esophagus. This ends up in this picture, which I've seen last Wednesday, in last case I've done. So you have to refashion your opening to adapt this funnel-shaped repair. In the first X-ray post-operatively, after we remove the tube, the feeding tube, and you put some dye to check your anastomosis, you may see that there is a discrepancy like this. It may look like stricture or narrowing. Maybe there is a degree of narrowing or stricture, but the natural look of both proximal and distal esophagus as such. This is a big proximal, a small distal, and this is how they look on the dye study. So actually we close interrupted, as you can see. We flip it over to close the posterior. As you can see, there's a flip over here. And I'm sure if Abdelmajid is around in the team, I've seen his name. He saw that the flip that we've done to close the posterior aspect. And we start first with the 2 stitches, and then we progress on and on until we achieve our anastomosis. This is straightforward primary anastomosis for a baby whose weight is okay, between 1.5 or 2.5, and he has no pneumonia and he has no anomalies and he can stand surgery. But as I said, this is the best part of the story. Well, we have a long gap now, and we talked about delayed and delayed management or staged management. Before we talk about what do we do in the long gap, what we want to do, try as much as possible to use the native esophagus. Native esophagus is the best lumen between oropharynx and the stomach. You can replace it by anything. You can imagine anything in the world, colon, small bowel, anything you want, part of the stomach or the stomach, but those are substitutes. They are not the original. They are not meant to serve in that part of the chest. They are meant to serve whatever they're being created for. We use them out of desperation. We don't say, let's go for a gastric tube. Let's go for a gastric polyp. Let's use part of the colon because it looks better. No, it doesn't. It doesn't anatomically and physiologically. They don't behave the same as a native esophagus. So I put first native esophagus, and we can do anything we want for it as much as it allows us. During the primary anastomosis, imagine there's a gap. It is about 2 to 3 vertebral bodies, and you try to pull the proximal esophagus down, and it is stuck at the apex of the chest cavity. It doesn't come much, and you have to bring it down. You bring the distal esophagus up, it works to the maximum. But then the esophagus in the top is not coming down. Ken Kimura, the Japanese in the United States, I think he's retired now, he created this helical cutting of the muscularis. The brown one or the dark is mucosa, and this is serosa or muscularis. So we go around and around. So he pull it down to help elongating the proximal pouch. Leviticus, he created circular, not helical, cuts and the serosa, and he pull it down. This is a multi-V, like the V and the V, this is V, and those helps, but they have limits. You don't expect by doing this, your proximal esophageal pouch will be so easy to come down. It is successful if that esophagus, the proximal esophagus, is ready to come down enough to you to meet the tip of the distal esophagus, but sometimes it fails. It is not a successful procedure in all long gap, but it is a procedure to keep in your mind, to keep under your hat. So if the time allows, you do your circular myotomies or helical myotomies or the multiple D myotomies. So you are cutting the muscle myotomies. So we do that. So a spiral myotomy or a circular myotomy by Leviticus in this fashion. Bouginage, as I showed you earlier, may help, may bring it from below and above. And this is when you just ligate your distal esophagus fistula and do a gastrostomy. So through the gastrostomy opening, you pass your bouginage from below and you put another bougie from above and you try to push them together. Well, there are two types of elongation also. There's the extrathoracic elongation where you put sutures around the two ends. This is blind, and there's a big distance. You see there's 1, 2, 3, and you try to bring them, they're not coming. So you fix multiple stitches here, and you bring them out, and on daily basis you keep pulling them. This goes up, distal goes up, the proximal goes down, and you are hoping with that they may come close until it looks like this. The problem with this that those sutures usually cut, and if it cuts, it's closed. You have to do something. So you have to be very careful, very gentle in doing so. And despite that, although you are very gentle and careful, sometimes it doesn't come very close. You have to find a substitute. Walker, on the other hand, this is why the baby is awake. Traction sutures elongation, as you can see here, to keep them intubated, ventilated, paralyzed, and he'll do this almost the same idea outside, and he try to bring them. He claims he has success, and he published papers since 2005 until now. Duplicating his results was not very much promising many times, but it is something to consider every now and then. This is using your native esophagus. Well, if native esophagus is not enough, and you have to find a substitute, something else to look for. Before I go to that, I talk about comparative study published in 2013, which is a comparison between delayed primary anastomosis and a focal anastomosis. Notice here, leaks are much more in the delayed primary anastomosis. This is meta-analysis. Strictures is much more, 155, only 5 in focal. The numbers are different, by the way. Focal had 71 patients, delayed primary anastomosis 451. From 44 studies, this is from 6 studies. So, in general, the leaks and the stricture is less, and it gives a hint that using a focal may be better than delayed primary anastomosis. On the other hand, also, focal have a shorter time for definitive anastomosis. The delayed, you wait for bouginage, for pushing the bougies both sides, so that they may come together. It takes much longer time, as I said earlier. So focal, in this comparative study, shows much better result in the way of leaks and in the way of stricture. The same thing applies for gastroesophageal reflux and esophageal. Let me go now to replacement or substitute. So, as I said, you can use anything you want. Think of any structure, tubulum, that can be transferred to the chest, and it's possible. And everything has been used. Colon has been used, stomach has been used in different ways and fashions, small bowel has been used, and each one has its own merits, has its own advantages, and its own disadvantages. This slide is very important. It summarizes the pros and cons of the substitutes. Let's go first to the colon. A piece of colon will be taken either from here or from here, from ascending or descending, and it depends on the blood supply, and which gives you more length up to the middle of the chest, and you transfer it as such. And usually there are 2 rooms, either substernal, just under the chest wall, or posterior. Those are the ones they use substernal because it's easier. You have to dissect your way under the sternum until you go up near the esophagus, and you create your anastomosis in the neck. But there is problems with it. There is massive reflux, lack of peristalsis. Colon does not propagate because your esophagus usually propagates to push the food down. It's not something just goes by gravity only. Gravity is there, but peristalsis is the mainstay of the picture, and you don't have that in the colon. The main problem of the colon, it dilates and dilates and dilates and creates pouches. It looks like divertically all over, and it is not a straight, single, smooth tube that you dream of, like the esophagus. With that enlargement and dilatation of the colon, you lose a lung volume, and the lung start to suffer, and the babies and the children, when they grow up, they have chest problems. And you have to have many anastomoses. One anastomosis from the colon to the upper neck, one anastomosis to the stomach, and anastomosis between the 2 colons. And with that, you have chances of leak. The highest number of leaks, not in the abdomen, but in the neck, between the proximal esophagus and the colon. And people accept a temporary fistula or breaking of the anastomosis, and they wait for it to heal by itself or by revision of the anastomosis. And it is not something patients like and the family. That's the colon. The same thing, in a way, applies to the small bowel, although people don't do much of small bowel because it is thin, it doesn't take acidity, and so on and so forth. But people think a lot about stomach. And stomach can be in 2 ways. Either taking the entire stomach, as you can see from here, you dissect everything here, you dissect everything, and this is the stomach, and you open it here, and you pull it up substernally into the neck, into the chest, all the way to the neck. We call it gastric transposition, and the slang way of saying things is a gastric pull-up. So we pull the stomach entirely into the chest. It means that there's a big volume of a stomach occupying the middle third of the chest cavity. In the past, people used not to do pyloromyotomy, so there will be some gastric distension. In early experience of Professor Spitz, when I used to work with him, I worked with him for 2.5 years or so, and I've seen him with pyloromyotomy and without pyloromyotomy. Pyloromyotomy makes things go with gravity, so you don't have massive gastric distension in the chest that will have the babies go into respiratory failure. But with pylorotomy, makes things easier. But what means you change the purpose or the job of the stomach from being a stomach into a long or elongated stomach behaving like esophagus. You have changed totally the entire anatomy into something else. It works. The results in the hands of Spitz are good. Repeating the same numbers of success rate did not happen very much in other hands. I was totally against him at that time. He used to get angry for me when I say I will not do this procedure and I will do only gastric tube. I was trained to do that when I was before coming to him in Canada, and I've helped, I assisted in the gastric tubes. It has its problems, reflux, although what I do is I do here a anti-reflux procedure between the stomach and the tube. The tube looks like a much more anatomical, like the esophagus, and I keep 50% of the stomach as a functioning stomach, which will dilate with time and go back to normal. Dumping is a problem. Same thing applies, but I found this much more appealing to me. And I've done that since I came back for the last 30 years without much of problems. When I say 30 years, yes, 30 years ago, I came back, the kingdom, Saudi Arabia, and I'll tell you a small story of this anatomy. I was making my first rounds in the pediatric ICU with the pediatric surgical staff who was there before me. It was my first day. So they are orienting me to the patients who are under their care until they reached a baby who was less than a kilogram, about I think 900 something. He was sick into DIC. The blood is coming from his ears, from his nose, from everywhere. Intubated, ventilated, and one of them, he said, don't stop by this baby, he's going to die soon. So I took interest, just like that. And I said, no, let's discuss him. What they did for him at that time, he had a lung gap, and one of the surgeons who was telling me not to wait, he said he'd try primary anastomosis, which did not work. The anastomosis disrupted. He took him again for resuturing, so it's a second anastomosis, and it also disrupted. So there's two chest tubes, pus coming out. The baby looks very sick, septic. As I said, he's dying. I took him, and what I did is nothing fancy. I did something like life-saving. I took him to the OR with minimal anesthesia because he was intubated, ventilated. I created a spit fistula, so I took the esophagus out in the neck, and I gave him a gastrostomy through the opening of, because chest was open and they have a pack in it. I just ligated the distal esophagus and just left things as it is. So it's like a gastrostomy. Essentially, it was a gastrostomy plus a spit fistula, and just said if any chance for him to live is by doing that. So minimize the filling of the chest cavity by saliva, dirt, and everything. He lived against all odds, all expectations. The baby lived for 1 year. His name is Adil. This is 30 years ago. He's 1.2. I was wrong. He was 1.2 kilogram. Yemeni. The father refused to continue the treatment. I spoke to the family. The mother pushed for the surgery. She said, if there's a chance for him to live, I want him to live. Because I think he was first baby. She has a daughter, and this is Adil, was the first baby boy for the family. So I said, well, I'll take him. So this father was totally against. So I gave him a split fistula and a gastrostomy, aggressive supportive treatment. 1 year later, I gave him a gastric tube, retroperistaltic. He had one anastomotic leak, then closed, and he had multiple dilatations. 30 years after, this is the boy. He finished his master's degree, he's healthy, he's working, and he's alive. So this is a survivor from 30 years. It didn't mean that all my patients on the same route. Some of them, despite all your aggressive treatment, may not respond to you. But I think it's worth trying to the last minute, especially in the long gap babies, to do something for them, and some of them will make you happy for the rest of your life. Well, let's go to the postoperative complication. I can spend hours on that, but it's been divided into the following under the 3 subtitles. Something related to anastomotic leaks, and it presents into as systemic infections or severe pneumonia, cyanotic spills, atelectasis, perfusion, tension pneumothorax. And believe me, if you work into esophageal surgery, you see this for sure. Sometimes you see all of those. If your leak is big in one patient, you will see tension pneumothorax, cyanotic spills, and so on and so forth. If they survive the surgery and they don't have anastomotic leak, they may have a stricture, and this happens usually in the week 4 and afterwards, and they present into dysphagia, regurgitation, into aspiration pneumonia, and more importantly, chronic cough and chest infections. This should be related to one thing. It should be related to reflux, gastroesophageal. You may dilate the baby, and you have to dilate the baby if you have restriction. And dilatation may go for 3-4 times, and then they don't need dilatation. But if they keep stricturing, you have to check, investigate gastroesophageal function by doing a barium study and see that there's a reflux. If there's a reflux, you have first to treat them with BPIs, proton pump inhibitors, aggressively, give them the medical management for reflux, hoping that it will disappear with time, because usually it disappears in the first year, but if it doesn't disappear in the first year, number one. Number two, if they have apneic spells and they aspirate, and you have a persistent esophageal atresia, those three together will force you to go for an anti-reflux procedure, open or laparoscopic. But at the end of the day, you have to have a medicine complication. Okay. The third complication of the repair is the recurrence of a fistula. What does the mean recurrence of a fistula? It means that the fistula tip that you ligated or suture was touching or facing your anastomosis, and it was not properly closed. And what happens is what we call recanalization. For that reason, and I've showed that to my staff in the last case, I put a suture at the tip of my fistula, the stump, and I hook it downwards. So the fistula tip will point downwards, not towards the anastomosis. This will minimize chances of a fistula recurrence. But fistula can recur from something else. If by chance, in the second or first or third night, post-operatively, the nasogastric tube comes out, and a very honest and sincere nurse who doesn't want you to know tomorrow morning that tube came out, she reinserted the tube. And unfortunately, when she is pushing, it went through the trachea. The fistula opens up. The same thing applies if the endotracheal tube comes out and somebody was trying to re-intubate and aggressively intubate the baby and not pay attention to the fistula that it is at the bifurcation of the trachea between the right and left main bronchus, and he pushes it and he opens it. And what happens then, you have a choking, you have wheezing, recurrent pneumonia, and so on and so forth. And you have then to do bronchoscopy and esophageoscopy and identify where's your fistula. But remember, it is not always a recurrence of fistula. Maybe there is a second fistula from the beginning, as I showed you earlier. It could be a fistula in the proximal esophagus that is not noticed. And the ones who operate on these babies, between the proximal esophagus and the trachea, there is a bridge, there's a wall, a common wall that you have to dissect it. Sometimes we get afraid to dissect it, or some of the surgeons afraid to dissect it, and they may forget that maybe there is a fistula there, that when you do your bronchoscopy again and esophageoscopy, you'll find that you did a good job in closing the original fistula from between the distal esophagus and the trachea. You did the primary anastomosis, and things are working very well, but you forgot that there is one fistula still available there. So it's not necessarily just a recurrence of fistula. Okay, we come to the survivals. By classification, gap not counted for. Remember this. Type A in this study, this just to remind you that what you see in the classic PITS paper or Waterstone classification may not apply in real life. Type C here, look at type C first, which is the commonest. This group from India, they published it in Saudi Journal. Type C, they had 388 babies they operated on. Check their mortality, 70%. Survival is 29%. With associated anomalies, survival 31%. Without, 31%. With anomalies, 20%. And the average is 29%. Type A, 36 babies. Their mortality is 26%. All in all. Without anomalies, 20%. With anomalies, and so on and so forth. So in total, the mortality is about 70%. And I put this to tell you that what you see in the glorious literature not usually available, especially in a tertiary care institute in India. Post-operative care are not very optimal. So we have to be careful. Lara means he went home by himself. We come back to and Waterstone. This shows you dark side of mortalities in the regular tertiary care institute. But in the hands of those surgeons, Spitz says he has a 97% survival, like 2 or 3% mortality. Same thing applies for Waterstone Group 1A, 100%. The real picture is between those two. It is never 100%. It is not 30% with a mortality of 70%. It is acceptable to have, and this is my experience, my survival rate ranges between 70 to 85% in 2 different studies, and that's to me is acceptable, which is international. I'm not saying that I have 100% always, and I don't think much of the surgeons whom I know they claim they have 100%. But you have to go by the book in doing your preoperative and post-operative care and division of your cases, selecting your cases. The ones who can go for primary anastomosis without a problem, they have to be selected as such. The ones who have to have delayed repair, they have to be treated as such. And the ones who have to have a substitute, esophageal substitute, also you have to plan which kind of substitute and stick to it. One of the worst things to do in esophageal surgery is to jump like a monkey. One day you are doing colon, next day you are doing a gastric polyp, third day you use an ileum, fourth day you use a gastric tube. You will never master any one of those, and you will be just reporting failure after failure. So stick to what you are good at and do it always. And with that, you have much better results than usual.
Dr. Talal?
I'm listening. I'm reading one of the questions, which I'll be answering. The question says, do you advise to do a tracheobexy as part of primary repair? No, I don't do tracheobexy can you hear me very well? Can you hear me?
It's a bit unclear, Prof.
Can you hear me?
Yes, now.
Hello?
Yes, now I can hear you.
Okay. What about the audience? Is there any problems? Because they said there's an echo. Is there an external echo there?
No, the voice is absolutely clear. Thank you.
Okay, I'll continue. This is the sort of first half. How much time left? About half an hour?
Time left, we have 2 minutes, and then we'll go for the questions.
Okay, I'll stop now, and let's go for questions and answers.
Okay. We've got a few of them actually right now. The first question that is bronchoscopy a prerequisite for all type of tracheoesophageal fistula?
I no, for sure not. If I have the facility, I do it myself, especially for the ones I'm a little bit worried about. But I know some centers, which I respect very much their way of doing things. They do routine bronchoscopy for all their patients. And I think some of the examining boards insist on that. And if you don't say that I do bronchoscopy for all my patients who have esophageal atresia and tracheoesophageal fistula, they may fail you. But in real life, not that easy to do in each and every case. I do it sometimes, and I select my patients accordingly. Yes?
Yes, Prof. The second questions we have is if the patient has tracheoesophageal fistula and duodenal atresia, which pathology you deal with? Tracheoesophageal fistula and duodenal atresia.
Duodenal atresia.
Yes.
Yes.
Which pathology you deal with first?
I hear you. Both are important to do and take care of. And duodenal atresia is a 20 minutes procedure. After I finish my tracheoesophageal fistula, I flip him around and do my duodenal atresia at the same setting.
Okay. The next question is what is the choice of investigation for H-type fistula?
Oh, H-type fistula, usually it is high in the neck. Even the approach is different. Some people will do an incision at the second intercostal space anteriorly. If you identify H-type fistula early on, it's a fistula. You will just ligate it and separate the esophagus from the trachea, because you have esophagus in continuity and you have a trachea in continuity, and you have no problem with that. The main problem with H-type fistula is discovery, it's not diagnosis. It is something that may be delayed to be discovered. And that's but the minute you discover it, surgery then is straightforward surgery.
Yes, Prof. They're asking if there is a room for initial tracheoesophageal fistula ligation only if the patient is critical or something.
Oh yes, that's the standard. This is the delayed surgery. Delayed surgery, it means that you have just to do the minimum at the first 24, 48 hours, maybe 72 hours. Means that you have just to ligate the fistula to minimize the air leak at the time of intubation, because what happens, the baby is intubated and he's hooked to the machine, but all his pressure, all the air goes in, it leaks through the fistula. It do two things. Number one, he doesn't receive enough oxygenation. Number two, his GI tract is full of gas and you can do nothing to it. So to save him from that problems, you just do quick thoracotomy, ligate the fistula, and at the same time, because you want to feed him, you give him a gastrostomy. So that's a life-saving thing for a delayed repair afterwards. Then you think of what repair you want to do. That's something to think about when he is in a much better shape.
Super, thank you, Prof. There's another two questions regarding tracheomalacia. And how do you discover them and how do you manage them?
Okay.
Is it mandatory to do aortopexy on all of them or no?
Well, tracheomalacia is one of the findings in patients with tracheal esophageal fistula and esophageal atresia with a certain degree. Some of them, they have severe form of tracheomalacia, and some of them mild to moderate. The mild to moderate or severe, first, they have to be discovered by bronchoscopy. And with bronchoscopy, when you put your bronchoscope, do rigid bronchoscope. I use rigid bronchoscope. By the way, I do all my bronchoscopies. I don't allow ENT to do it. My philosophy in that is if you are going to do a procedure, it has its complications. You have to manage your complications. So I do bronchoscopies, and when you put your scope, the trachea is collapsed. And the minute you go in, it opens like a fish mouth. So we call the tracheomalacia classic presentation by bronchoscopy a fish mouth appearance. And if you pull your scope, it collapses again because the cartilage rings did not mature enough to hold itself. Thoracotomy, and you find your trachea and you just hang it like a tent with 2 or 3 sutures, Proline, to whatever structure around it. So it opens up the trachea, and that's aortopexy. But for the mild to moderate cases, you wait for time and you reassess them. If they continue to have a brassy cough, there is a very special cough that the babies with tracheomalacia shows. You have to observe that and ask the family to tell you with each visit how much the cough is affecting them. And that's for the tracheomalacia.
Super, thank you, Prof. We've covered most of the questions, so if you want to go ahead with the esophageal...
with the caustic agents,
yes.
Ingestion.
Yes,
yes.
super,
So,
thank you.
This is a quick introduction. Corrosives may induce a rapid, progressive, devastating injury to the GI tract in this setup, I mean the esophagus, and the mediastinal structures. It is accidental, usually in children. In children less than 10. But for the adolescents, it may be not accidental. It could be suicidal, especially in one study in the females. They drink something to die. What a nasty way of dying. We used to see this in the past, in the last 30, 40 years, as causative agents. But in the last few years, buttons or button batteries started to show up. And the American Academy of Pediatrics issued a lot of literature warning families that the effect of swallowing buttons or button batteries is so detrimental, so fatal, that the burn will happen within less than 2 years, 2 hours, and the injuries could be a lifelong injuries. And I'll show you a case history at the end of this presentation of one of my patients. So it is something to remember. So the types, it could be liquid of any form of alkali or acidic, which I'll come to that, or it could be a button that sticks somewhere in the esophagus. The worst place to stick in is the middle esophagus, and I'll tell you why when I come to that in the next few slides. So swallowing button batteries can be as fatal as other agents, liquid agents. Alkali is the commonest, and it has a worse effect. It has a liquefying necrotic effect. It goes deeper in the tissues. It injures at the upper esophageal and oropharyngeal tract. It doesn't go as the acid goes down to the stomach. On the other hand, the acid, it has a burning effect in the mouth. So it may burn the mouth, and it will not affect much the esophagus as it has a coagulation necrosis. Because it has a burning effect, the penetration limit the penetration of the material is limited. To be swallowed fast, it goes to the stomach, and it has, this is the reason that It has another more problems because of its taste and odor. It will be vomited and it will create much more burning effect. It produces skip lesions with distal perforation because it lands in the stomach in comparison to the alkali. Okay, this is a new classification which is only published around 2012. They call it the drool classification, the drooling effect. The best is number 2, the worst is number 0. If baby is drooling saliva, if he is reluctant to eat, if the burn severe in the oropharynx, and there is fever, abdominal tenderness, retrosternal for the ones in the chest, but there is nothing here. So this score is high, his white count is high. So drooling or the drool protocol or classification, 0 is bad, 2 is the best. This is more of a medical early presentation of the problem, not a late presentation. But the baby comes to the emergency room, and always there's a pediatrician first, and he will look into the drooling, the saliva is coming out, and he does not want to drink. Well, so what to do? Immediate therapy, and this is for us as surgeons and also for pediatricians. But the key successful management depends on 2 things. Identify the severity of the injury and minimize the extension. Somebody will ask a question here. Minimize the extension means dilute it by milk or water? No, don't. And number 2 is to know the type and the amount of the agent. Is it alkali? Is it acid? How much? And the utmost important thing here is to secure the airway and to be sure that the baby is breathing. He may have a perforation in the stomach, he may have a perforation in the esophagus. Well, I know that's one of the complications of corrosive agents, but I want him to be breathing. I want him to be hemodynamically stable so I can do something for it. So sometimes, most of the times, if he is really sick, we intubate him and we want to see what the time of intubation, we want to see the oropharynx. Take a close look at the oropharynx immediately there and then. This is quick before you do anything. Obviously, you start an IV, you may give him some antibiotics, but don't pass him as a gastric tube immediately. That's a no-no. Don't give him milk. Hopefully that will dilute your acid or alkali. It has bad effect. So you have to know some history, little bit of examination. And within 24 hours, if possible, if the baby situation allows you to go for endoscopy. The indication for that is stridor, intended suicidal ingestion, symptomatic children, oropharyngeal burns. So all in all, you want to check the passage from the oropharynx all the way down to the stomach. It's essential also to do a chest X-ray. You may not see anything in chest X-ray, and don't say that minimal can be seen in that X-ray. That X-ray is the base or the basic X-ray to build on it. You will see things happening at later stage. So you will detect if there's an infiltration because of aspiration, and detect if there's air in the mediastinum, if the swallowing of the material is extensive, there's too much ingest, or if there's a battery. People build their slides on the liquid ingestion, and they forget that he may present to you as the case as put it on purpose. Remember the battery ingestion. He may present only with difficulty of swallowing. He may present that he cannot eat, and he may missed for a week. Okay, this is also another algorithm by American Academy of Pediatrics, and it's almost medical, but it has a surgical touch in it. Corrosives, if it's early, within 48 to 72 hours. If it's mild or at early endoscopy, discharge, clinical follow-up. If it is severe in the first 24, 48 hours, at early endoscopy, surgical gastrostomy, endoscopy, dilatation after 3 weeks. Well, this is to be discussed. Delayed presentation after 3 days, after 3 weeks. Well, no endoscopy immediately because you may perforate. If he needs feeding, you give him gastrostomy, if there's severe dysphagia, endoscopy again, and dilatation. And here you will find a lot of pathology happening in the esophagus, multiple strictures, long stricture, pouching, and so on. If it's a late presentation after 3 weeks, endoscopy, because healing happens here, and dilatation. If it is successful, you keep following him by endoscopy and dilatation. And if it is not successful, you have to go for surgical gastrostomy, retrograde dilatation, and so on and so forth, plus some surgery here. You may have to have substitution. You may use colon or stomach. Most patients with grade 1 to 8 injuries have good prognosis without sudden death, and they will not develop obstruction restriction. 70 to 100% of patients with grade 2, B and 3A develop stricture, and this is here we work and we use dilatation. For patients with grade 3B injuries, mortality is high, and you have to be aggressive in your management if you want to save their lives. Esophageectomies may be the way to go. Colonic or jejunal and gastric may be the way to go. They did not put here gastric because in the acidic, the stomach may be affected, and you may have a shriveled, fibrotic stomach, useless to be used, and you have to think of some other structure, either colon or small bowel. Well, let's go for endoscopy. What is the purpose of doing endoscopy? As we say, it's a gold standard. Number one, to tell us about the presence of the lesion. And for that reason, most of the endoscopists, usually they shuffle the scope all the way through. This is their routine of working. But the ones who are aware that maybe the injury in the oropharynx, the minute they pass the tip of the scope above the tongue, on the tongue, they start to visualize for any pathology in the oropharynx and in the distal pharynx and then in the upper esophagus and so on and so forth. So it will tell you where is the pathology. The other thing is to give you the severity of the lesion. Is it a grade 3? Is it in depth? Is it superficial? And the extent of the lesion. It could be just limited in one place. It could be all over. It could be mental. It could be in 1, 2, 3 areas. This would make you plan your treatment accordingly. If there is a suspicion of a lesion down the stomach, you have to inspect all the way to the stomach and the duodenum. The fourth thing is meant for the battery, the presence of objective evidence correlated risk of perforation if there is a battery in there. Well, this is the findings. Zagros has a classification used since 1993. Grade 0 is normalization, me and you. Grade 1, edema, hyperemia of the mucosa, so it's very light. And usually this is in liquids like Clorox, not flash. Clorox has a mild mucosal effect. Grade 2A, superficial ulceration, erosions, friability. It's easy to bleed by passing the scope. Grade 2B, it is the same, plus deep, discrete, or circumferential ulceration. 3A, small, scattered area of multiple ulcerations and necrosis. And that's the main thing. You start to see in grade 3 necrosis. In A, it is not big areas, but in 3B, extensive necrosis. In 3B, usually this kind of patients here who will need substitution of the entire organ if it's affected all. Here, there is a risk of perforations in 3A and 3B. So risk of perforation is high here. Okay, this is in A, slight swelling, redness of the mucosa, but not much. In B, presence of superficial ulcers. This is an ulcer. If you touch it, it bleeds, and there's some exudates. In C, this is grade 2B, local and encircling ulcerations. This is C, it is points only, 1 point, 3 points, but this is encircling. You find it everywhere. Deep ulcerations. 3A, focal necrosis, areas of necrosis, there's a black area here. In E, indicates extensive necrosis, it's white. Compared to this is pink, although it's a bit hyperemic, but still pink all over. And this is here badly necrotic. This is saliva, by the way, and this is whitish. It means it's necrotic. White, necrotic doesn't mean black. That's escarp. This is white, means that there's extensive necrosis. Okay, contrast study is not immediate and should show. Nobody in the first week or two will do it. You will do it after the first endoscopy to delineate the amount of stricture in the esophagus and the affection of the stomach if it has been affected. The study should include the esophagus and the stomach, not only a barium swallow, but a barium swallow and meal at the same time. It identifies the esophageal stricture, if it's there, single or multiple, and the length of the stricture. And to plan the next move. Shall we dilate if it is limited, or shall we substitute if it is not limited, if the stricture is bad? Okay. To plan next move, substitute, yes, you have to do something here. You cannot do this. You cannot dilate this. In comparison, here you can dilate. This is dilatable. Dilate, you have so many ways. Balloon dilators, rigid dilators, so many things. And you can achieve it. Even if you have 1 or 2, maybe 3 separate small strictures, limited stricture, 1, 2, 3, you can dilate them. It will take longer time, but as we said earlier, native esophagus is the way to go, is the one to keep, is the one to work with, even if you are suffering yourself. I've done 2 patients. I didn't do only dilatation, I dilated, and one of them continued to be there for longer time. So I have to go for thoracotomy and do a strictural blast. So I open it longitudinally and close it transversally. And the girl got married 2 years ago and she's fine. So you can do something for limited strictures, although it could be 1, it could be multiple. But for the ones with a long stricture, that's nearly impossible to be dilated, and it has to be. I will finish. What's time now? I'm sorry, I took you longer than I expected. I will finish with a third choice. We said either substitute or dilate. Is there a choice? A third choice? Yes, there's a third choice. And this is example. Jury is a year and a half years old, female Saudi. She was playing with a disc battery, and by mistake, she swallowed it. Family did not know, and she had dysphagia. She has difficulty in swallowing. She will not eat. She refuses to eat. They took her to 3 hospitals before coming to us, and they said that she has sore throat. And they treated her with antibiotics, with cough syrups, with just standard medication. The father was a military man. He took her to us. I was in the military hospital then, and a chest X-ray was done and showed a foreign body in the middle. This is X-ray. I mean, the man did not even took an effort to do a chest X-ray for somebody who has a sore throat. Just let's assume she has a sore throat, do a chest X-ray, especially if she is persistent to do so. I was away at that time, so they called the endoscopist, the adult endoscopist, and he had difficulty in putting this. It was there for a week. Imagine a battery staying in the middle of the esophagus for 1 week. So he pulled it. He mentioned to me when I came next day, he said it was difficult to pull. He had the grasp for biopsy, forceps, and he pulled it with difficulty. It came out, and he was happy. So he sent her to the ward, and he said next morning give her food. Chest X-ray post next day showed effusion and intestinal air. By the time they fed her, she went into respiratory failure and jealous. Immediately they intubated her, and it was difficult to intubate, difficult to ventilate. I was out of the city. I came with this situation. Somebody who is in respiratory failure, arrested with the X-ray like this. So I took her for endoscopy, esophageoscopy, bronchoscopy, and I found that there is a hole in the esophagus and there is a hole in the trachea. I took her for a right thoracotomy, excised 1 centimeter of the middle esophagus with primary anastomosis, and I closed a big tracheal defect primarily after freshening the edges. She healed very well. She needed esophageal dilatation a few times, and this is her today's X-ray. She is in grade 2 in the school, and this is X-ray sent by the father to me today to show you. So there's a third one. Corrosive ingestion is detrimental, but esophagus is forgiving if you follow the gold standard procedures of how to save it. I think we tried to cover the congenital defect to corrosives to the maximum in the last 2 hours. I apologize if my coverage was not enough, because this is 3 big topics. I have so many slides to show you, but I think I'll stop at this point. And thank you for your patience in this late Friday afternoon. And I will be happy to get some questions.
Prof, I'll just ask you a quick question and then we'll conclude. Regarding the corrosive injury, what technical pearls you would like to give us to avoid further injury to the esophagus, and what type of scope do you use, rigid or flexible?
I use rigid. I think, well, you are good at what you are trained to use. I use the flexible every now and then. But in my institution, many times I did not have a proper flexible scope. So I use rigid, and I'm so happy with it. And I'll continue to use it. I think it's safe if you know how to use it. And it shows you, especially if you have a camera at the tip, you will see everything, and your attendants will also see everything. And I can pass a long forceps through the scope, and I can pick the foreign bodies. For the foreign bodies, there are foreign bodies in the chest, the esophagus, or in the trachea, and I can see things all the way through. I can dilate through it. So it is my tool that I use it all the time. But I will not blame anybody to use the flexible. The flexible, even if you pass it without inflating air, you have to push it through the esophagus without seeing, and you may create injuries. If you inflate, also it may create injuries. So I'm a little bit afraid of using flexible, but people use it, and I will not blame them.
Prof, really would like to thank you for the excellent presentation and extensive review of the topic, actually of the topics. And we all know that you are one of the most senior experts in the country. So we really highly appreciate your time and effort, especially that it's Friday and afternoon. So thank you very much. الله يجعله في ميزان حسناتك و thank you for your time.
شكرا جزيلا لكم كل الزملاء اللي بيسمعوا. And I appreciate their patience. Really thank you very much all of you. And I hope I can meet you sometime again. Thank you. Assalamu alaikum.
Thank you, Prof. For all audience, thank you for attending. We're gonna send you an email for the feedbacks. And if you have any concerns, any questions, feel free to send us through the email. Follow us at our Twitter account for any new updates. And thank you for attendance. Thank you and bye.